Volkmann's contracture. The anatomy. The bones included are the humerus, the radius, the ulna, the carpal bones, the metacarpals, and the phalanges. It involves the median nerve, the compartments of the forearm, and the muscles involved are the flexors of the wrist. It can involve the extensors, but it's not as common. Compartments of the forearm. There's two compartments, the anterior compartment. The muscles included are the flexor carpi radialis, palmaris longus, flexor carpi ulnaris, pronator teres, flexor digitorum superficialis, flexor digitorum profundus, flexor pollicis longus, and the pronator quadratus. The posterior compartment includes the brachialis, extensor carpi radialis longus, extensor carpi radialis brevis, extensor carpi ulnaris, the anconeus, extensor digitorum, extensor digiti minimi, abductor pollicis longus, extensor pollicis longus, extensor pollicis brevis, extensor indicis, and the supinator. Pathology. A Volkmann's contracture occurs when there is a lack of blood flow to the forearm due to increased pressure because of swelling. It causes permanent flexion contracture of the hand and wrist. It is very rare, 0.5% of the population. It causes intracompartmental pressure. Majority of these contractures are caused by a supracondylar fracture, but they can also result from fractures of other areas, crush injuries, burns, arterial injuries, or neglected compartment syndrome. There's 3 levels of severity or grades. Mild is a flexion contracture of 2 to 3 fingers and no loss of sensation. Moderate, all fingers are flexed and the thumb is oriented in the palmar orientation. This can cause the fist to remain permanently in flexion and there is a loss of sensation. Serious, all muscles in the forearm, flexors, and extensors are involved and it is severely limiting condition. The muscles involved, the flexors, most commonly the pronator teres, the flexor carpi radialis, flexor carpi ulnaris, flexor digitorum superficialis, palmaris longus, flexor pollicis longus, pronator quadratus, and the flexor digitorum profundus. Mechanism of injury. Not one specific mechanism, but usually caused by underlying internal conditions. Can be caused from animal bites, fractures of the forearm, specifically a supracondylar fracture, bleeding disorders, burns, excessive exercise, injections of medications at the forearm, prolonged compression from a casting or a tight dressing, crush injury or trauma, or a severe contusion of the forearm. Signs and symptoms. Decreased sensation, paleness of the skin, muscle weakness and loss, deformity of the hand, wrist and fingers, or swelling and shiny skin. The 5 P's of a Volkmann's contracture includes pain, pallor, pulselessness, paresthesia, and paralysis. It can cause a bleach view at the skin level, which is pallor. The wrist is in palmar flexion, clawed fingers. Pain occurs with passive stretching of the flexors. Palpation of the area creates persistent pain. Pulsations cannot be felt in the affected arm. Decreased sensation, and then observable motor deficits. There are no special tests. There are no predisposing factors, but there are diagnostic procedures. So you can do an X-ray. You can do an intercompartmental pressure. It can be measured using 2 techniques, the infusion technique or the pressure transductors, and then you can have surgical intervention, and it is considered when the absolute ICP is greater than 30, or the difference between diastolic pressure and ICP is greater than 30, or the difference between mean arterial pressure and ICP is greater than 40. Management and treatment. Prevention is best with this condition. A fasciotomy is recommended when ICP is above 30. This is done to prevent the onset of a Volkmann's contracture. In mild cases, you can get away with just progressive splinting and passive stretching. Moderate cases, they do surgery to make the tendons longer to prevent the contraction, and then physical therapy. And in severe cases, debridement of injured muscle and scar tissue, or an emergency fasciotomy to decrease the ICP. Physical therapy is mandatory to improve function after this surgery. Referral and immobilization. Refer to a surgeon or physical therapist depending on the severity. Splints are used in mild and moderate cases to help passively stretch out the hand. Differential diagnosis. It could be a pseudo-Volkmann's contracture, a distal radius fracture, or myoglobinuria, which is the presence of myoglobin in the urine. Prevention. Keeping good blood flow in the forearm. Any splints, bandages, or other devices that obstruct blood flow be removed. A fasciotomy may be used as a preventative measure so the ICP doesn't become too high and cause the contracture, and the best means of prevention is early diagnosis. There is no Mulligan's concept. In my PICOT analysis, 28 people with a Volkmann's contracture ages 4 to 28. A total of 54 fingers were involved. The intervention was myotenolysis. This is where they go in and make the tendons longer. This in patients with the contracture caused by fractures versus no fractures. And then the outcome is 2 patients had mild tendon release and 26 patients had full ROM after the intervention. And then the time is an average of 16 months.